Laura Rariman, our president-elect, a few more months from now, will be introducing our main program today. And Laura, as a reminder, is president of the Group Health Foundation and the VP of Community Responsibility, Group Health Cooperative. So she'll be moderating this panel today. So Laura, show's yours.
Thank you very much. Thank you very much for this time. As our panel gets settled, let's start with a few analogies to understand a snapshot of American healthcare today. So imagine if your house was built the way healthcare is delivered. So you would have electricians, carpenters, plumbers, all with their own blueprints, occasionally talking to each other. That's a problem. What about cost? Well, we know that we waste dollars in duplicative tests and unnecessary procedures, but how much? It actually is estimated to be $750 billion, that's with a B, annually, which is 1 year of the Department of Defense's budget. And finally, how efficient are we? Well, if the banking system were run like healthcare, we would be standing at our ATM machines for days waiting for our cash because of unavailable or misplaced paperwork. So as was famously said one time, Houston, we do have a problem. In fact, we have three main ones. First, 46.6 million people are uninsured in our country, and that number is rising. Second, we have a cost crisis. 17% of U.S. GDP is consumed by health care. That number is rising unless we make some changes. It's bankrupting individuals, and it's putting U.S.-based employers at a competitive disadvantage. And thirdly, we have high rates of variation in care, unnecessary care, and variation in care that produces patient infection and even death. So where are we today? Well, healthcare reform is underway. Passage of that new law about 2.5 years ago immediately launched some consumer protection issues. One, our sons and daughters up to age 26 can stay on our health care coverage. Secondly, there is now health care coverage for people with pre-existing conditions, and preventive care is covered. And finally, lifetime and annual benefits caps have been removed. But come January 1, 2014, only 15 months from now, many more changes to our healthcare system will be enacted. Our panelists today will help us understand the implications for our businesses and our own healthcare, and just how fast the moment is approaching. So finally, food for thought. Atul Gawande, a physician and an author, has been very influential in shaping our public thinking and conversation on the need for healthcare reform. He said, quote, "The one truly scary thing about health reform, far from being a government takeover, it counts on local communities and clinicians for success. We are the ones to determine whether costs are controlled and healthcare improves, which is to say, whether reform survives," end quote. So it's up to us. We're fortunate today to have some excellent panelists to help us understand the issues. Commissioner Mike Kreidler has served as Washington State Insurance Commissioner since 2000 and is currently running for re-election. He's been deeply involved in healthcare reform since before the law was passed. The federal law is a framework. However, it is made real when the details are hammered out at the state and federal levels. Thanks to his leadership, Washington State is one of only a handful in the nation that are ready to implement healthcare reform. Steve Hill, on the other end of this panel, is current chair of the board of directors for the Puget Sound Health Alliance. It tracks and publicly reports quality performance of physician groups and health plans. He retired from Weyerhaeuser as Senior VP of HR and then served as administrator for the Washington State Healthcare Authority, overseeing health plans for all our public employees and low-income state residents. He is currently director of the Washington State Department of Retirement Services and chair of the Robert Bree Collaborative. It's a public-private partnership appointed by the governor to reduce medical inflation and increase quality outcomes. Finally, Diana Rakow is Executive Director of Public Policy and Government Relations at Group Health. Diana leads a team that works to track and influence policy on the state and federal levels to improve the healthcare system. Diana served in Washington, D.C. as Health Policy Advisor to the Senate Healthcare Committee and Senator Max Baucus. And that's our panel. So I have 2 questions for our panelists, and in order to have time for your questions from the audience, I'll ask the panelists to confine their responses to 2.5 minutes. And let's start with Commissioner Kreidler. So can you tell us what is the biggest thing happening in your world right now of interest to this audience? Oops, are you on? No, we should be. Ken, we might be. We have a dead. There we go. Check those mics. Thank you.
It was too close. I couldn't read it. I'm an optometrist by profession, so the biggest thing that we're involved in right now is implementing healthcare reform, as Diana outlined. We're building a healthcare reform on the private insurance system. That's what passed the Congress. It's probably the only thing that would have wound up being successful in passing the Congress, to build on what people are familiar with. And to go to the numbers that on a state basis for the number of uninsured, we're talking about 1 million people, over 1 million people who are uninsured in the state of Washington. But don't be misled just by that number, because 1 out of 4 people in the state of Washington are either uninsured or underinsured. And if you take a look at the underinsured and uninsured in just the ages from 19 to age 64, you're talking about 1 out of 3 people in the state of Washington. If they don't have the financial resources to address their own medical costs because they have high deductibles, more catastrophic type coverage, those costs, if they don't pay it, then get shifted to other payers. And we're talking about in excess of $1 billion a year just in the state of Washington. Right now, we've created a Washington State Health Insurance Exchange focused on the individual or family market and the small employer market. And that's where individuals will be able to access either subsidies for their health insurance program or for their health insurance coverage and be able to have that coverage. So that is the most important part of what we're doing right now.
Thank you very much. Next, Diana.
Thank you.
Oop, another mic.
I think that works now. Great. Thanks, Laura. The Commissioner referenced all the work that's going on right now around healthcare implementation, and it really is tremendous, and he's shown some great leadership in that area. The amount of regulatory work and change and ongoing legislative work and change is obviously a huge thing that is going on also for group health and for all of us. But I wanted to reference something else, which is that all of this work around health reform underscores something that actually has been a long-term theme at group health. And for all of us now, it's sort of health reform 2.0. And that's improving affordability of care by improving quality. There's a couple of examples of what that looks like. We found at group health, for example, that just by allowing patients to email their doctor and have longer appointment visits and call consulting nurse 24 hours a day, we could reduce emergency room visits by 29%, giving patients other ways to access care, giving patients a more patient-centered experience, a closer experience to their physician and care team, can improve some of those high-cost ways of utilizing care that drive healthcare costs up. Another example, recently in one of the largest peer-reviewed studies of its time, something called shared decision-making was reviewed. And shared decision-making is really actually common sense. But it's a set of peer-reviewed, evidence-based tools that doctors and patients families work through together to decide what the right choice of treatment is for a patient. And by just using these tools at group health with our patients that are maybe older and need joint replacement, we saw a reduction in hip replacements by a quarter and knee replacements by a third, with a commensurate increase in patient satisfaction. Patients were glad that they had chosen the right option for them. And at the same time, those choices can over time bend healthcare costs down. But it's not enough if we just do it inside our own four walls or with our own groups of patients. So the next phase is working across organizations, building clinical integration, care teams, and guidelines that extend between organizations like group health and others in the community. We're trying to do this right now in Spokane with Providence, Tacoma with the Franciscans, in Everett with the Everett Clinic. But those kinds of partnerships, many of which you're hearing about in the paper and in just stories around the community, I think will offer the promise that these small changes can help bend cost trends over time by improving quality and patient care.
Thank you. And Steve, from your perspective, what do we need to know about?
Hello. Good afternoon.
No?
Yeah, my technical paperwork. I can't use yours. Hello. Welcome. I'm tempted to do a Clint Eastwood here and talk to the empty chair, but I would like to piggyback on the comments that Laura made, and that is, if you take the $750 billion of waste that the Institute of Medicine estimated in their recent report, and you take that down to our state level, it's about $15 billion a year in our state, and that means it's approximately the same amount as our total general fund state budget. So waste, and as Steve Covey said, every system is perfectly aligned to get the results it gets. And our medical system is perfectly aligned for medical miracles, high rates of overuse, high rates of misuse, high rates of underuse, high waste, high rates of defects, and overall a lot of waste, of approximately 30%. And in my opinion, is the largest challenge our economic and political systems face, and that is figuring out how to actually turn the money we spend on healthcare toward health and away from waste. So the exciting things that I'm working on right now are at the delivery system level, and I'd like to focus, and I think to really do what I just said, I think you're going to have to change the way we pay for healthcare. And just in the last 2 months, we at the state, with a lot of work with other people in the community, have applied for an innovations grant, which is part of healthcare reform. 5 states will get up to $50 million to do innovations, and we have applied for one of those large grants to do payment reform innovation in this state in 2 areas: how we pay for OB care, which has enormous levels of variability in it and serious quality issues associated with it, and in chronic care, which is a major cost factor and lacks a lot of coordination. And there's a lot of evidence that if chronic care was more coordinated and paid for differently, there'd be better outcomes and lower costs. So that is, and it's being done by the state. The state is the lead sort of agency in this, but it's going to have heavy involvement of these collaboratives that Laura mentioned, both the Puget Sound Health Alliance, the BRE, the Foundation for Healthcare Quality. This community is very fortunate that we have a lot of provider groups, as Diana mentioned, and collaboratives that are working on trying to improve the quality and reduce waste in the delivery system.
Great, thank you. And second question for Commissioner Kreidler, what do you think, we do have elections coming, what should Washington State be working on regardless of how the elections turn out?
Well, regardless of how the election turns out, the Affordable Care Act is the law of the land, and we have an obligation to continue to fully implement it. And quite frankly, as you look at the challenges we face with the huge amount of expenditure, we're number 1 in the world for spending, we're 37th for outcomes as a total population. We've got to make improvements. If it isn't the Affordable Care Act, then what? Because the status quo was unsustainable. So we're going to proceed full speed ahead regardless of what happens on November 6th. That's not going to make any difference. If the rules are changed, we'll do it differently, but we need to make sure we're implementing the law to benefit all Washingtonians to the fullest extent we possibly can.
Thank you. Diana?
I agree we need to move forward with health reform and implement the exchange and move toward having more people get coverage. I also think that we need to make sure that people understand what they're getting and are able to make informed choices. And that's something that, just given how complicated this law is a little bit more challenging. And both Steve and I have talked about quality, but the devil's in the details when it comes to how do you define quality and how do you make sure that people have actionable information that they can understand, that they can translate, and know, okay, so what's the right high-quality choice for me, for my family? And right now, the Puget Sound Health Alliance is doing a ton of work to make sure that that information is out there. But I think we need to go one step further and make sure that in the exchange, there's information so that people can understand what their options are. Taking a note from Medicare, where Medicare Advantage plans are actually rated on a 1 through 5 star basis now. And that information is readily available on the website. It's translatable. The 5 stars is a compilation of about 80 different measures, so you don't have to nitpick through all the different measures, but you can get kind of the way when you shop on Travelocity or something for hotels, you see a rating. And I think we need to move more toward that kind of information, making consumers able to make good choices for themselves.
Thank you. And Steve?
So I also think we do have, and the governor would want me to say this, that we do have to move forward with implementing healthcare reform, both the insurance aspects that Commissioner Kreidler talked about, but also the expansion of Medicaid. But also we need to do, as I said earlier, a lot of work in the delivery system, and this community, this state, is well positioned to continue to make significant progress in the improvement of our healthcare delivery system. And I would work on 4 things, and one of them Diana's already mentioned. I think, first place, we do have to change the way we pay for healthcare, and we need to do that thoughtfully and probably treatment or disease type by disease type, not some grand big bang change in the way we pay for healthcare. But we do have to move away from fee-for-service healthcare. That, I think, if we don't do that, we will never be successful at this. We need a significant more transparency in our healthcare system. I don't believe there is any aspect of our economic system that is as opaque as healthcare is. And we need a lot more visibility in on costs and price, and a lot more visibility on quality and safety aspects. You know, you can look at our airline industry and you can find out what the on-time records of all the carriers are. You cannot go on and find what the wait times are for various healthcare providers in this community. You can go onto the web and you can look at every accident that occurred in general aviation and commercial aviation in the last year. You can go on the web and look at it on the FAA website. You cannot do the same thing in healthcare. And we know that somewhere between 100,000 and 250,000 people a year die in the U.S. due to medical error. So I think a lot more transparency in the system is critical. Prevention. We pour all this money into the sickness system, into the medical system, and there is enormous opportunity to improve health by dealing with obesity, by dealing with tobacco, by dealing with substance abuse. Half of all deaths are preventable, and 2/3 of those deaths are a result of tobacco and obesity. So we have a huge opportunity around improving and stopping, by the way, the epidemic associated with our children and obesity. And then finally, just to echo what Diana said, for this system to work, we need much higher levels of informed patients and consumers, and so that they have an idea of what is going on to them and what is going on in the medical system. Thank you.
Thank you very much. I think we need to open this up to the floor, and Ken is going to reclaim a couple of mics here, and we have people with mics around. Please remember, this is an emotional topic. We're not looking for your statement. We're looking for your questions. And so please construct those accordingly. So thank you very much. Is there a first question out right here? First question over here. Larry Granite.
Thank you, and thank you for enlightening us here this afternoon. You mentioned the devil is in the details. And I've heard that, and I've read it, and I've seen it online, but I don't know what the details are. I hear those on the right saying there's new taxes coming. What can you tell us about some of the details? You may not know them all, but what can you tell us about what we might expect in this new Affordable Health Care Act?
I'm going to let the commissioner take that one. I will just clarify my comment. And just one of the things that I have found so remarkable about this experience is how unpredictable it is. And that's not actually meant as a scary thing. It's just so much of the healthcare system now is changing that we are waiting for and we are dependent on decisions and guidance from regulators, from legislators that represent us and are informed by us. And it's a constantly moving cycle. And so those details are, constantly emerging, and we're learning to be adaptive and change with them. And it's a challenging process, but it's also pretty inspiring as well.
There's a lot we don't know yet, and the biggest part of it is that we're still waiting for clarification from the federal government in order to move forward with healthcare reform. But let me just describe to you how it's going to really wind up changing, particularly in the individual or family policies and then for the small employer market, because they're going to be separate pools that are created. But that's not something that people see. What people will see is that healthcare is going to be offered on 4 different level tiers. The same coverage has to be provided. The difference is how much out-of-pocket expense are you going to experience. That will be true inside the exchange, which is a public-private partnership made up of nominees that come from Republicans and from Democrats, and you have one of the Republican appointees, and Bill Baldwin sitting right back here, who is an active voting member where I'm a non-voting member. But what it means for you is that you're going to be able to make choices then comparing apples to apples in ways you haven't been able to do it before, whether it's because you want to have 60% covered by insurance and 40% that would be paid by you, or at the top level, 90% paid by the insurance and 10% by you, obviously costing more, costing less, but you'll be able to compare plans, both inside the exchange where it'll be very comparable, but also outside the exchange because they're going to have to meet the same standards. And that's a radical change from what we've seen in the past.
Thank you. Steve has a comment and a mic.
Well, I think it's a great question, and I'll just say a few words about payment reform. We know that fee-for-service medicine basically rewards high-volume medicine, and the person making the decision about what treatment you get has an economic interest in those decisions, and so it has a feedback loop in it which may not be benefiting efficiency or health. So now we all agree we want to change that. So we want to pay for outcomes, we want to pay for health, we want to pay for people getting good treatments and high quality treatments. But exactly how the devil is in the details is how do you do that? How do you risk adjust? How do you measure what you pay for, et cetera? And that is what the devil in the details example would be with payment reform.
Good, thank you. Lillian.
Question from Bill Robinson.
A big chunk of costs are driven by defensive medicine, including the unnecessary tests and office visits referenced earlier. Political realities preclude any serious consideration of significant tort reform in the short to mid-term. Would you comment on this issue, including prospects for any kind of control or progress in the future?
Bill, the biggest change that needs to take place is that we need to start offering health care that follows evidence-based best practices. And if you do that kind of treatment, it makes it much harder for litigation to take place. If you have that kind of recognized standard approach, particularly when it deals with chronic disease. As for moving away from the tort system, I'm not opposed to that, but let's make sure we're doing it for the right reasons. And working on what Steve mentioned a bit ago was that there's a lot of unnecessary tests, but also medical errors that happen in the system. We certainly want to make sure that the people are held accountable. But moving toward evidence-based best practices, in my opinion, is the strongest way to bring down tort liability. It's interesting to note, though, when we look at the cost of medical malpractice insurance, since in the last 8 or 9 years, we've actually seen medical malpractice rates falling rather significantly in the Washington market, and it's true nationally, too. So there is a trend of going down, but we can make it go down faster.
Thank you.
We have a question over here.
Steve Hill, I had a question for you. You said something about a change in the fee-for-service, and I didn't quite get what you were saying. Could you elaborate on that?
Sure, Faith. Just that our current healthcare system is built around a model that when you go in, let's say you have diabetes. When you go in for the treatment, you get paid. The doctor is paid by the office visit, the tests, and a whole menu of things that the doctor is paid for with diabetes. An alternative to that would be to stratify diabetic patients by severity and then pay the doctor an annual fee that would be based on that patient maintaining blood sugar levels at a reasonable level. And the number of tests and the number of visits, who does the work and so on, would be between the patient and the doctor. But what you'd be paying for is a course of treatment for a year with the goal being maintain blood sugar levels. So that's just a rough comparison. I just want to echo Mike's comments about liability reform. I'm a state agency director and I don't like getting sued, so my instincts are sort of on the side of the question. But also as somebody that has spent 32 years working on healthcare policy, the degree of variability that's in our delivery system is intolerable, and to me, the first thing we ought to do is reduce the variability and create these safe harbors that Mike mentioned, and that is the way to deal with tort, I think.
Thank you. Lillian.
Pete Delaney?
As one of the small business people with fewer than 10 employees, the term uncertainty comes to mind. And what I'd like you to speak to is the cost, coverage, and care. We joined a large medical group trust, my group did, and now we're told we can't be a part of that and that we'll be going into an exchange. We joined a trust for cost, care, and coverage. Will the new plan allow us the same coverage, cost, and quality of care?
When it comes to association health plans or health trusts, we've worked very closely with Sam Anderson out here to make sure that it was done the right way with the Seattle Master Builders, and that's an example of how they can survive even with healthcare changes and reform. But it's interesting when you look at small business. I mean, I think there's a lot of paranoia out there that somehow they're going to be under a requirement to offer health insurance, and that if they don't, there will be a penalty applied to them. Neither is true. Small employers under 50 face no penalty, and there's no requirement that they offer health insurance any more than it would be for people who buy their own health insurance as individuals. But what they will have, one is that they're already eligible for tax credits up to 35%, starting in 2014, and actually goes to 50%, up to 15% eligibility for tax credits in order to provide health insurance. And they're going to have better choices in the market, much more akin to a large employer when they make their selection. That's an advantage for small business, often seen as a disadvantage between the large employers and the small. That's levelized. The second is that they're going to have a much broader chance, an opportunity, not a chance, an opportunity to have a broader selection for their employees of the health plans that they do wind up selecting. Something that right now with the small group market, they're very much limited as to what those options and choices would be.
Is there time for one more?
I think we do not have time. Sorry, Lillian, I'm getting the signal from the boss. Thank you very much. Thank you very much.
Seattle Rotary Online is made possible in part by a grant from First Choice Health, working with the Washingtin Health Information Collaborative to use technology to bring better health care to patients throughout the Pacific Northwest. First Choice Health.